Welcome to our Q&A session. We're going to be putting the firing line by the members in the group, but welcome back. We've had a nice summer break. What have you been up to?
I've been traveling. So thank you for inviting me on, Van. It's very nice to be on.
As I said, we'd have a live Q&A session, so we're putting Mr. Singhal and myself in the hot seat. And I've got some questions now. These questions have come from the Instagram and from the Facebook group. And some of these questions have been asked just generally in the Facebook group. And I've purposely not answered in the group because I thought they would be good to answer in this live Q&A so we can share the information, not just on this social media platform, but also on YouTube. And there'll be snippets on Instagram coming up. And that all relies on me editing as much as I possibly can. So bear with me. So the first question, Rishi, I wanted to ask you is, what's the state of play with bariatric surgery in the NHS? Because we've got a lot of members in the group that are thinking about surgery that may be on an NHS waiting list. And I think it's always nice to share that insight with our members.
So it's been a difficult year for everybody. I think it's been a difficult year for the NHS. It's been a difficult year for our patients. It's been a difficult year for friends, and it's definitely been a difficult year for doctors and staff. I think last year there was hardly any bariatric surgery, and we all know that. That is unfortunate, but it is where we were. Even this year, things haven't been positive so far. So I work at the Heartlands Hospital, and we are trying our best. I must assure you that we are all trying our best to make it happen so that we can restart bariatric surgery within the NHS. But so far, we haven't been able to do many cases. I think we've only been able to do a handful of cases this year so far.
Right.
But we are still soldiering on, trying to see how we can. One of the difficulties has been having green pathways and red pathways separate. And as a result, the hospital capacities have gone down. So I think we are working on it, but our waiting list is long at the moment. So we are trying. Let me assure you, we are all trying our best to sort it out. We are in the process, but we haven't got there yet.
Right. So the waiting list, how long? I know it's really frustrating for the patients, but it's out of your control. What sort of time span are we looking at for waiting lists now for weight loss surgery?
Now that could change. That could improve. Last week when I did my bariatric clinic, I said approximately 3 years from the time they talked to me. But that could suddenly change. If suddenly we have capacity, then I think it would change.
Right.
But at the moment, I'm quoting 3 years, but I could be wrong. I don't think it will ever be longer. It could be shorter as soon as we have a plan of how to deliver our services. And I'm telling you that all our team are working very hard to get it sorted. So I tell all my patients that it's 3 years for now, but just hang on, let us see what we can sort out and we'll get back to you.
And what is the waiting list like in the private sector? Is there a waiting list, or because I know you've been busy?
In the private sector as well. I think it's at least 4 weeks for some complex cases, maybe 3 months or 6 months, but that's for complex cases. So, when we operate on a patient who's 100 BMI, why don't we start there? Let us discuss the processes involved in a complex case and an easy case.
Go on, let's go ahead with that question.
And that would explain to patients that why it takes time in any kind of setting, the NHS or the private. But I'll give you an example of the private sector. I'm doing a patient's procedure in October who is over 40 stone. So where does the process start? For a patient who's 45 stone, I need to have lots of clinicians who participate in their management. So firstly, I got this patient seen by a cardiologist. The cardiologist did an echocardiogram to see an ultrasound of the heart to see if the heart is working well. But then the cardiologist wanted to do a stress echo. So put the heart under some stress and see if the heart will tolerate a major operation. Then we referred the patient for sleep apnea testing because the patient was snoring, had lots of problems with that. And we got a BiPAP machine prescribed, which is something for obesity hyperventilation syndrome. To optimize the patient with that, it took another 3 months to get the patient optimized. Now, the patient's weight is quite high, so we decided that let us help the patient with the very low calorie diet, which you can manage in a patient who's 30, 35 stone. But at 45 stone, you need to have drugs to reduce the weight along with the diet. So we prescribe the patient Saxenda. So the patient has been with us for 6 months now, having seen me almost 6 months ago. Besides all the other workup, the patient has seen a cardiologist in private, a respiratory physician in private, a diabetologist, endocrinologist in private, all of whom work within healthier weight. And now the patient is ready for surgery in a month from now.
Right. So they've had to have a lot of preparation to get to this point.
Yes. And imagine doing these processes in the NHS, it takes a bit longer, of course. So even in private, it has taken us 6 months to get a patient fit. But that is what underlines the processes and the things involved in bariatric surgery. On the other hand, patient who's 35 BMI, has a mild medical problem, just let's say blood pressure, they just need to see a surgeon. And at healthy weight, they all see an anesthetist always on the phone 5 days before surgery to make sure they're fine, and then they can have surgery. But we have to make sure that we do it safely, of course.
Absolutely. No, and that's great that patient's had that support and prepped for surgery. And I think it's, like I always say, weight loss surgery is all about managing the patient's expectations, not just mentally, but medically as well. And I think that's really, really important. So, right, let's hope that, things go well when you operate on that patient, and you'll have to let me know how you get on with that patient, but it sounds quite challenging.
Well, you've been involved with so many complex challenges. We are working together on a patient who needs a renal diet post-operatively.
Yeah.
So why don't you tell us, when a patient has renal failure and they have obesity operations, what are the complexities that you face in that patient?
Gosh, you're throwing me in the deep end now. So look, many, many moons ago, I was a renal dietitian, and I worked with patients that had dialysis. So they were either on hemodialysis or COPD, which is great because we're now finding that dialysis has improved so much that patients can eat well and the survival rates are better. But we now have the other issue that patients are eating better, they're gaining weight because the renal diet can be quite restrictive. So with this renal patient, we've had to check how well the kidney function is and how diet might affect that. Now, sometimes it can be the amount of protein that they have in their diet can affect how well the kidneys, the load that we put on the kidneys. Now, with this patient, it is pretty much just healthy eating advice, but it's more about managing that patient's expectations because the supplements that they need to take post-surgery, hydration, are they on a fluid restriction or not? Do we have to watch how much salt that they have, how much potassium they have in their diet? So we have to look at blood results quite regularly and also monitor the type of medications that they're on. So, and also I think this patient's also diabetic. So we're also looking at blood sugar levels. So we have to watch the amount of carbohydrate that they have in their diet. And again, that can affect the pre-op diet. So there's never really a straightforward patient, but especially when it comes to kidney function, we have to be extremely careful. Now, before, the only sort of weight loss surgery that we would perform would be a gastric band because it was the safest procedure. But we now know that sleeves are okay to have for these patients, and they're probably going to have a better outcome. So lots of monitoring with fluid status, their blood results being monitored, the amount of protein that they've got in their diet. But then also we're looking for some weight loss as well to help improve blood sugar levels. So it is quite a complex case, but I'll be following that patient up post-surgery to make sure the protein content is satisfactory. There's so much to look at, but it just naturally rolls off the tongue when I'm talking to the patient.
I think our listeners need to know that if they have a complex problem, I mean, like this patient has diabetes, patient has renal failure, has had a transplant, and is going to have bariatric surgery now to reduce her diabetes and her blood pressure and the risk of her kidney getting rejected. You need a dietitian who can not just manage bariatric diets, but you need a dietitian who knows about diabetes, and you need a dietitian who knows about renal medicine. And actually, when this patient came across, I just couldn't think of any other names but you, so that we can manage this patient safely and properly.
No, absolutely. And, even patients that are on some sort of renal dialysis can have weight loss surgery, believe it or not. But now also with transplanted patients like this lady, now that the transplant medication, you don't have to take so much immunosuppression and so forth. And again, patients feel so much better and their restrictions are generally relaxed. They can eat better. So now that, again, the side effect of having transplant surgery is the fact that they're going to put weight on.
Yes.
So these are all things that, and especially when you've been on dialysis for so many years and you want to live your best life, weight can be a bit of a hindrance.
Indeed.
But I'm sure we'll be fine.
Perfect. These are the complex things that we sometimes deal with, but enough of the complex work.
And that's why having an MDT is really important. And I always stress that. I've always got Rishi if I need to call up for any advice, and he's always got me. But that's the way that we work.
Good outcomes for a patient one. We need a team like you and I working together for our complex patients. If a patient needs some other kind of bariatric surgery, needs a different bariatric operation, if they have emotional eating and you think they'll benefit from something else, I think those are the things that we discuss to get better outcomes for our patients now.
No, absolutely. And I think, and this wasn't a patient that had surgery with healthy weight. This was another company, and the patient I was looking after post-surgery had a serious issue, and she'd contacted this company and someone gave her some advice and she just didn't feel it was right. So she called me up. She's one of my clients. And I said, that isn't right. You're bleeding. That's fresh blood. It's not old blood. And it was just lucky that I knew the surgeon. It wasn't you, Rishi. It was another surgeon that I knew. Called him up, got the patient admitted, was admitted, I think, for just over a week to be managed. And, so it's always good to have good support as well. Okay. So, right. Okay, let's kick off with questions. So I've got a question here from James. James had a gastric bypass just over 12 months ago, and he's been diagnosed with reactive chemical gastritis and prescribed lansoprazole 30 milligrams per day by his gastroenterologist. James was initially vaping but stopped after a hospital admission. The GP at some point stopped the lansoprazole to do a stool sample, and because he stopped the lansoprazole, he went downhill and ended up in A&E after a couple of bouts of melena, which is losing blood in his stool. His iron levels have plummeted. He had an endoscopy where they discovered James has 2 ulcers. And what he said is one of the new bypass pipes and diagnosed with chemical gastritis. He's back on the lansoprazole and feeling much better, but he is getting some pain after eating certain foods, which he's trialing. But he wanted to know, what is reactive chemical gastritis and the long-term implications of it?
So let me get straight to the point, which everybody who knows me will know that I do. This is not down to the PPIs or the tablets, or down to your GP stopping your drugs, or anything else in this world. This is only due to vaping. So let us make it clear that if you were vaping after gastric bypass surgery or gastric sleeve surgery, you are doing yourself damage. Smoking before surgery is dangerous because it increases the risk of ulcers or chest complications. Smoking after surgery is plain simple dangerous. And please, let's not kid ourselves that vaping is any better, because it is the nicotine content which does the problem. It is not the tar in the smoke that causes the ulcers. It is nicotine. Then some patients come and ask me that, can we take flavored electronic
vaping,
flavored vaping? There is no evidence to show that flavored vaping is any safer. So till that there is any evidence to say that actually it is okay, I don't think we should be doing it. And I personally don't think it is, because serving up these chemicals in a vapor format has never been studied before. In the past, we used to have chemicals in the form of a smoke. Now they are in the form of an aerosol, which is what happened with COVID. When you serve up chemicals in an aerosol format, they penetrate much more and they can do much more. So let us be clear that we should not be smoking before surgery or vaping, and we should certainly not be smoking or vaping after surgery. And chemical gastritis is caused by these things.
Yeah. Okay. But James, that wasn't a lecture for you. Rishi was just trying to educate the members, but we know that you've stopped vaping. We know that you're feeling better. When you said that you're getting some pain, that possibly is from your ulcers, but also when you take lansoprazole, what it does is it changes the acidity of the stomach so the ulcers can heal. That means that your gut flora, that's the bacteria that grows in your stomach, that will change, and that may cause some intolerances to some foods. So it could be that. It could be the fact that you might be eating a little bit too quickly. It might just be general pain from the ulcers with the fact that food is impacting on them. So fingers crossed that will get better. But I hope that answers your question and you feel reassured. But like I said, that was an educational sort of educational information for the whole
Whole group,
the whole
yes.
group. Yeah.
So that the group knows about the dangers of smoking, and I know that you're not smoking anymore, so it should be fine.
Yeah, great. So second question, Rishi, alcohol. Why do we tell our patients to limit alcohol before and after surgery?
Again, simple. Before surgery, every unit of alcohol has calories attached to it, firstly. So a unit of alcohol has at least 100 to 150 calories, can go up to 200, 250 calories, depending on the alcohol you take, the mixer you take, and the nuts you have with it, of course. So if you're having 20 units of alcohol, you're almost having 4,000 calories. Now, if you are on a diet, a real diet, then you need to be having 12 to 1,300 calories a day. 4,000 calories will be food for 3 days. So in just having 20 units of alcohol, you've had food for 3 days, essentially. So
that's if you still work with calories, right?
Yes. So that is the problem with alcohol and calories. Second problem, of course, the addiction part of alcohol is a problem. We don't want patients to be addicted to alcohol. Now, you will understand this more if I talk about the post-op problem. When we take away diet as a comforting food for you by doing surgery, patients want to substitute it with something else. If you're already used to alcohol, you can substitute it with alcohol, and it will be very easy to become addicted to alcohol post-operatively. That is why we have to ensure that you are not addicted to alcohol pre-operatively, because otherwise there's a much higher chance to be addicted to it post-op. And of course, the calorie problem still exists. That is why we advise patients to be not taking more than 10 units at all pre-operatively. If they are taking more than 10 units, then they have to cut down to 10 and know that they can maintain it there. But somebody who's over 30 units, I will not operate on them.
Yeah, and I think, I understand, Rishi, and that's fine. It's something that we screen in our calls when we're speaking to pre-surgery patients. But we've got to remember that, alcohol is calories, as Rishi said, but also post-surgery, your sensitivity to alcohol is heightened. And what that means is that it's not going to take very much alcohol for you to be actually very happy. So you're a cheap date, as I always tell my patients, that you've got to be mindful. But also when you drink after you've had weight loss surgery, you have to be not just be wary about the amount and the volume of alcohol that you're having, but you end up eating mindlessly. And what I mean by that is you might end up eating and drinking together that can make you dump and make you feel very unwell. But also, your food choices will change as you become a lot more relaxed and, you start snacking on the sliders. So again, the calorie intake. And I completely agree with Rishi. We have to be mindful about transfer addiction here, because when you have a problem with your weight, you may be using food as a coping mechanism to resolve emotional issues, whatever it is, stress, manage certain symptoms. And what we've got to be mindful about, that once food is taken out of the equation, that you don't start to use alcohol as your coping mechanism, because liquids are easier to eat than solid food. So we have to be careful about that. Now, some surgeons ask their patients not to drink again, but I think you and I have got slightly a bit more relaxed attitude, and it's probably maybe a bit more realistic that everybody, well, not some people will like to enjoy a drink socially, special occasions. So we generally, my advice is generally for the first couple of months, avoid alcohol, because your stomach is healing and we don't want to irritate it. Thereafter, I always say try a small amount of alcohol before you go out at home, because you need to know what your tolerance level is like. And it's just to be aware that, you've got to be very mindful about the volume of alcohol that you drink and the habits that you create when you are drinking alcohol. And I think as long as you're doing that, it's pretty safe to drink.
Yes.
Yeah. Okay. Right. There's a question here by Amna in the group. And I think I'll be able to answer it, but it'd be great to know your thoughts as well. Is there a chance you can become lactose intolerant post-op?
Difficult question to be exact about. It is unlikely, but this is just my basic surgical opinion. I think if you are not intolerant to start with, you won't be intolerant after surgery, but we do not understand these operations fully and completely. When you bypass the first 1.5 meter, the food is really meeting the bile around at 1.5 meters. So direct exposure to undigested milk at that point of the bowel, can it suddenly make you intolerant? Possibly. Do I know for a fact that it will? I don't know.
Yeah.
So it may not. Hard to say.
Yeah, my thoughts are that you can develop some form of lactose intolerance. It's only because I probably speak to more patients than Rishi post-surgery, and I get the calls. And my reasons are exactly what Rishi's just said, that we've messed around with the anatomy of your stomach to perform a procedure, and the stomach is upset. Secondly, a lot of the meal replacements that you're having have a lot of lactose in, and it just may be too much for your stomach to handle. So the lactose intolerance that you develop post-surgery may not be permanent. It may be just temporary. The other thing is that all of a sudden you start to introduce these medications that change the acidity in the stomach. We call them PPIs. What they are, like lansoprazole or omeprazole, and they change the acidity in the gut. And again, the bacteria that grow in the gut to help lactase, that helps digest the milk, may thrive in an acidic environment, and your stomach isn't as acidic as it needs to be for that enzyme to thrive in. So that can cause some lactose intolerance. So when you stop that medication, you might find just after 3 months or 4 months, all of a sudden you're fine with lactose again. So that's my theory, and I think it seems to fit in with the times when people are having problems with milk and dairy, and then all of a sudden they seem to be fine. So if you do develop lactose intolerance post-surgery, it doesn't mean it's going to be permanent. It's likely that you will be able to have some form of dairy 3 to 4 months after surgery.
Absolutely.
Yeah. Okay, I think this is a question from me. It's Nicola. She's 4 weeks post-op. She's got great weight loss, but her energy levels are low. She says she's so tired. Is this normal? So Rishi, do you want to answer that from a surgical point of view?
Well, immediately after surgery, for the first 4 weeks, your calorific intake is not the same that it should be. Plus, you are in a state of catabolism. When we have cut something and joined it, even though it is laparoscopically, the body is in a catabolic state, so it takes a bit of time to recover. But this is only temporary. I won't be too concerned about it. Of course, we have to think of the completely outside causes. Is there a complication? Is there a real problem there? But most patients are a bit tired and feel weak for the first 4 to 6 weeks after surgery. But I think it will then improve. But I'll ask what Van thinks about it.
Yeah, no, I agree. I think it's all to do with the fact that, one, you've had surgery, you've had something like Rishi said, catabolic, which just means that your body's burning a lot of energy. That's why you have that rapid weight loss initially. So, and then your body is trying to recover from the surgery itself, the trauma of the surgery. But also, you've got to think about the fact that pre-surgery, well, before you start the pre-op diet, you probably had a really good nutritional intake with lots of calories, and probably well over 2,000 to 3,000, maybe even 4,000 calories a day. Then you have 2 to 2, maybe 4, sometimes even 6 weeks of a pre-op diet. So all of a sudden we've cut your calories down to really low, and the diet is low carb. Then post-surgery, you really struggle to get those meal replacements down. And then when you start to progress through your textures, you're not really eating very much. So you're going to be in a huge calorie deficit. So you're not eating enough. So it's very common to feel tired because your body's recovering. Your nutritional intake is completely different to what it was pre-surgery. And your brain is still thinking, where's the rest of the food? Where's the rest of my energy? So your body's still adapting. So that's possibly why. So it's normal. It generally is normal. But Nicola, I'll catch up with you. I think I'm speaking to you tomorrow, so we'll review that. Right. I think this is another question for me, but you might be able to help me, Rishi, seeing as you keep talking about calories.
I think working
worried
with you,
about my job.
I have become more of a dietitian working with you. I've started understanding what diets are about and what requires to be successful from after surgery. So obviously every surgeon, when they become a surgeon and a bariatric surgeon, they think they can sort out obesity. Well, they're wrong. They can't. Bariatric surgery is a tool. And the most important thing in that tool is a good patient, and a patient who can work with us, and a dietitian who can explain to the patient how to work with us. So I think I've learned more and more that it is not just about the surgery. It is about what we do before and after the surgery, which makes you successful.
Yeah, I'm sure you'll get some CPD points for being on this Q&A session, Rishi. Maybe I will too. So it's good. We're learning from one another, and also we're helping the group as well. So Angie, who is a Heartland's patient, I remember her back from Heartland's days, and I don't know whether you operated on her or somebody else, but she's asked. She's 3.5 years post-op, and I've been reading her posts in the group, and she's struggling a bit, and she's asking what sort of calories should I be on 3.5 years post-surgery. And I'll be honest, that's a really difficult question to answer, and it's not going to be simple, because 3.5 years post-op, I know that you're struggling with a bit of regain. So this isn't about what maintenance, this is about losing some weight. So I don't talk about calories to my patients, and there's a reason behind that, because that's your background, that's your comfort zone. You know, you've been dieting for most of your life and it hasn't worked, so you've had weight loss surgery. So I always say, when something hasn't worked for a long period of time, we have to change that thought process. So you're in this dieting mindset of you're either on a diet or you're off it. You're either exercising fully or you're not exercising at all. And what we have to do is, we know it doesn't work. Okay, that's why you've had weight loss surgery. So we need to think about creating some balance. But your mind is automatically wanting to go back to the comfort zone of, oh, I know what's going to help me lose weight, a diet. But it isn't about dieting. And we have to look at that term, what your thoughts are. You're going to think about restriction, cutting out all the foods that you enjoy. But what we really need to do is create as much balance as we can. So I would say, go back to basics, go back to eating 3 small meals a day, check in with yourself if you need high protein snacks between meals, eat slowly by chewing your food, using that small side plate, and also how mindfully are you eating? Because sometimes, you know, if you're watching TV and you're eating, your body and your brain don't register the fact that you've eaten, so it's still looking for more food, and that could be one of the reasons why you might be eating between meals. The other reason could be that, you know, you might be a bit of an emotional eater, and you just need to figure out what your triggers are to eating and manage them. So I would definitely get in contact with your aftercare support team and see if you can have a one-off consult and assessment just to see where you're at. You know, I've had patients post-surgery having a calorie intake from 1,000 calories a day, some even less. Some people are on 600 to 800 calories. It's too low. Your body cannot survive on that sort of calorie deficit. But I've also had patients on 2,500 calories, and you must be thinking, what, 2,500 calories? But yes, I remember I've had patients on 2,500 calories to maintain their weight, and it's difficult to get that sort of nutrition in after weight loss surgery because your stomachs are so small. So that's why I say this isn't an easy question to answer. I'd be looking at what you're eating, track what you're eating, and see what sort of foods aren't serving you to get to where you want to be. And I think that's probably the best way for you to go about it. Have you learned something there, Rishi?
It was a difficult question. I was hoping that you won't ask me. Actually, this brings me to a very, very interesting point. And I'll ask you this question. I did a lecture for dietitians. Can you imagine me lecturing dietitians when I was in India? And that was quite silly. But anyway, I tried to be smart and I lectured them. So one of the dietitians asked me an intriguing question, and it was almost embarrassing being on stage when I was asked this question, that she said, I see patients at 3.5 years after surgery who don't get the same feeling of satiety they used to get before surgery, at the time of surgery. And they have started now gaining weight. How can I stop that? And how can I help them? And she asked me, and I just did not have a very intelligent answer. So what would you say to that?
Literally just how I've answered the question. I think with most patients, you know, we know that, you know, 50% of patients can start to regain a fair amount of weight if they haven't got good support. And that's because I think, you know, bariatric surgery is permanent. It's not a temporary surgery that's going to sort of, you know, it's going to disappear. And you've got to remember that our patients have spent most of their life being overweight, struggling to get to where they want to be. So it's not just a physical condition, it's a mental condition. And for anything, when it comes to working with your mindset, you know, I've got this line that I tell everybody, all my patients, progress has no finish line. You know, after you've finished working with me, you've got to carry on. You might even have to tap in for accountability support now and again. And I think what happens with bariatric patients is that they have that honeymoon phase initially. the first few months, and it's like, oh, I've got my head hunger, I've got everything sorted here. You know, I finally feel in control of my weight and what I eat. Then the reality kicks in when that honeymoon period sort of disappears. And all of a sudden, yes, they've got a regular eating routine. They know they need to have snacks and it all seems to be working well. Then the support goes. Then all of a sudden the old habits start to creep back in. And of course, you know, if you've been overweight for about 20 to 30 years, you're not going to recover from your old mindset in 3 months, 6 months, or 9 months. That old mindset is always going to keep returning. You've just got to have the tools to know what to do when they do return. So I think that's the main reason why a lot of patients may put on weight. So if you think about it, eating slowly, it's difficult for us that haven't had surgery, let alone when you have had surgery. So, you know, a lot of patients start to eat quicker. Their texture of food goes back from firm textures to soft textures, because if the food is soft, you don't have to eat so slowly. The old habits of mindless eating, maybe the fact the prepping and planning, you know, to lose weight. There's a reason why they call it lifestyle change, because your whole lifestyle has to change. And if you think about it, your lifestyle pre-surgery would be very different. And then post-surgery, you're forced to make these decisions, one by us, but secondly, by your stomach. But also the sensation of not feeling full does happen because of the textures and not eating as slowly as you should be. But also stomachs stretch a little bit. You know, they're never going to feel like they did the first few weeks after surgery, because there's so much inflammation there, because, you know, you've just had surgery, the stomach's upset. It's like anything. It's like a ring. You know, when you put, let's say if you're overweight and you've got a ring on your finger, it's going to feel tight. But as soon as you start to lose weight, it loosens off and it becomes normal. And it's the same with surgery. It's all going to feel very different. But then afterwards, your habits and behaviors are going to start to creep back to where they want to be. So I think that's probably why now for some patients, they will stretch their stomach and that's due to the old habits returning. But I really do think it's a mindset game.
Perfect. I'm with you.
Yes, so it's
it's
the old habit.
Long question, but you answered it so well. Yeah, that's what we need really.
Sorry, it's a bit long-winded, but in short, it's a lot of it is mindset and habits, and changing habits isn't an easy process for anybody, including me. So the second part of the question is, what should I be doing because she's got gallstones, low-fat diet, which is generally healthy eating. So you need to steer clear of the sliders, which are high in fat and sugar. And I hope that helps, but go back to basics. And this is where I think, you know, with a lot of my patients that struggle with weight regain, it's about creating new habits, routine, but also I do reset them. But I'm not talking about a patch reset, I'm talking about a mind reset. So if you're interested in that, looking for a discovery call. But that's what I do with my patients to get them back on track. And it's not easy for the patients, it isn't, but it's part of the process. You have to accept that you've got to change, and until your mind accepts that it's got to change, you're always going to go back to the old version of you. Mm-hmm. So right, we've got a question here from Amy. It was a general question, but I thought it'd be a nice one to have today. Hey all, I'm on day 6 of my LRD and I've had 646 calories today, which is very low. Yes. Only managed 1 shake. Now, is there a reason for shakes only, or am I okay if I stick to under 1,000 calories a day? Can I answer this first? And then I'll ask you, Rishi. So the pre-op diet on average can be anything between 800 to 1,000 calories. And what we're looking for is something that's low in fat, but also low in carbohydrate, because we need to shrink the liver. And I'll ask Rishi why we need to shrink the liver in a minute. So if you're doing 646 calories, that is a bit low. But the odd day like that isn't a problem, but try and stick between 800 to 1,000 calories. Now, the reason why, I think part of your question is about, is there a reason why I need to stick to a liquid only diet? And my answer is don't stick to a liquid only diet. We only really advise our patients to be on a liquid only diet if they've got a lot of weight to lose pre-surgery, if they've got fatty liver, or we suspect there is a large liver there. I always tell my patients to have at least one meal a day, and there's a reason for that, because if you don't, post-surgery, you're going to be on a 2-week liquid-only diet, and you're going to be gagging to chew some food, and it is the wrong time to be eating solids. So I always advise my patients to incorporate at least one meal so they're still chewing food, because post-surgery, if you've been on liquids for 2 weeks, then you're on another 2 weeks of liquids on the post-op diet. You're going to want to chew food, and we don't want you to chew food at that time because the stomach is healing. So please, if you're on a pre-op diet, if you can, stick to 2 meal replacements and 1 meal a day. So Rishi, why do patients have to follow a pre-op diet?
A lot of glycogen is stored in the liver. So when you eat food and you get carbohydrates,
Can you just let us all know what glycogen is? I know what it is, but just to explain.
So when we eat carbohydrates, so sugars, we use what we need, but whatever is not needed by the body, that is stored in the body. And liver stores most of the glycogen of the body. Now, when there's glycogen stored in the liver, it becomes quite heavy, and the stomach is underneath the liver. When we have to do bariatric surgery, we have to lift the liver by something known as a liver retractor. It's a metal instrument which is used to lift the liver up. But the liver cannot be lifted if it is heavy with glycogen. When we do a liver reduction diet, we mobilize all these carbohydrate stores. Mobilize means move the carbohydrate stores from the liver to support your body. Your body can't survive on 800 kilocalories a day. All these calories that are already there in the liver are mobilized then to support your body and to keep you working. And as a result, the liver reduces in size. The abdominal wall also becomes soft. So this is another thing that I've realized. In somebody who's over 30 stone, and I do a lot of surgery for patients who are 30, 40, 50 stone now, their abdominal wall is quite thick, but our instruments are of a fixed size. When you go through a very thick abdominal wall, the movement of my instruments reduces, and it makes surgery quite difficult. However, if you've done a good diet, this movement starts becoming very easy. So not just the liver is reduced in size, which improves the quality of your surgery and improves the possibility of doing surgery. The surgery itself becomes easier. Your lung compliance improves. Your diaphragm can move much better. So everything happens after this. So we usually say for somebody less than 40 BMI, 2 weeks is more or less adequate. Yeah. Between 40 and 50 BMI, we say 3 to 4 weeks. And over 60 BMI, we can go up to 6 weeks for some patients. And I know my patient that we were talking about earlier, he's been dieting for almost 8 weeks and with a drug on top of it to get the liver reduction, to get the abdominal wall softness, to get the lung compliance improving. So there's a lot that happens in bariatric surgery, which we need to look after to give you a good outcome.
Yeah, and also it's safety, isn't it? And also one of the other reasons why, if we shrink your liver, the cavity where the stomach is, you don't have to pump in so much gas, which makes the recovery a lot better. Is that correct? So less shoulder pain.
That is correct. If you increase the abdominal wall compliance, which is the ability of the abdominal wall to stretch, we will not have to put so much gas in. We won't have to struggle so much. Your outcomes, your operation will be slicker, better, but overall outcomes will be better as well.
And I know one of the questions that we always get is in the group, I'm really worried my liver hasn't shrunk, and I always say there's no need to worry. If you've stuck to the diet, it will shrink. So I think it's compliance again. And I know, look, we're all human, and one bad day isn't going to ruin your entire 2-week pre-op diet or 3-week to 6-week pre-op diet. One day isn't going to. And if you're going to have let's be realistic here. Most weight loss surgery patients will have a food funeral. And what that means is they're going to enjoy all the foods that they really enjoy, and they may treat themselves to before they have surgery, but do not do it in the 2 weeks before you have your surgery. I always say that. Do not have a food funeral. And also, the other thing that I've started to say, because Rishi will call me to let me know that he's found food in the stomach, is if you can, go on a liquid-only diet 24 hours before you have surgery, so the stomach is empty. So that's the other piece of advice. And that's just feedback from Rishi. I mean, he calls me up to say, oh, I found chicken or something like that in the stomach, and then I'll be like, right, okay, then let's do this. Let's get everybody on a liquid-only diet the day before surgery to ensure the stomach is completely empty, because some of us have stomachs that empty at a slower rate than others. So we just to be mindful about
diabetics have diabetic gastroparesis. So
yes,
the stomach works slower. So in diabetics, you may even go on liquid diet for 2 or 3 days before surgery just to make sure the stomach is empty.
Absolutely, absolutely. Right. So next question, it's not a question. it's a thank you to you, Rishi. And it's not from me, it's from one of your patients, Leanne Hudson. No questions, but 2 years post-op and she had a gastric band. She's lost 7 stone. So just to say thank you. And she's
Leanne,
8 weeks post tummy tuck. Fantastic.
Leanne, thank you for letting us be a part of your journey. So thank you very much. And I'm pleased. And if you need us, just let us know.
Yeah. So talking about gastric bands, Rishi, what are your thoughts on gastric bands and their popularity? Do they still have a place in weight loss surgery?
It's a difficult question. You know, I used to be very fond of bands and I still like bands. The problem of bands is, let's start with the NHS. We are unable to provide the kind of care they require. Bands have a good are a good operation, but the amount of work you need to do with the band, the amount of care you need to provide, and the amount of lifelong care you need to provide, let's face it, it's just not possible. And as a result, bands get a bad name, but it is actually the post-operative care that should be getting a bad name, that we are not able to provide that. And as a result, bands don't work. And there's only 5 or 6 countries in the world that are doing bands as a result of this. Now, in the private sector, we are doing a much better job. Of course, we have, the NHS has its own constraints. So I won't disregard the NHS in this. We cannot provide a lifelong follow-up. In the private sector, of course, patients pay for a lifelong follow-up and they can get a lifelong follow-up if they pay for it. And you can look after bands much more. But as a result, generally the popularity of bands is going down. But the bigger problem is, when bands were in vogue, sleeve and bypass were higher risk operations. In 90s and early 2000, sleeve and bypass were higher risk and there were much higher complications. Now we know that we can do a sleeve in less than 30 minutes and patients are home within a day. And the risk of sleeve has gone down. The leaks and bleeds are just not seen. You don't see complications with sleeves. So the competition of the band has become much safer than what it used to be 20 years ago. So that is why bands are declining. My personal opinion is that they will continue declining, unfortunately, whether we like it or not. And we don't shape the market. We are just providers of the market. But the market demand is going down.
Yeah, and I see that as well. I think we all see that, don't we? Working in weight loss surgery. So we've got some questions coming up in the group. Well, actually, here's another one, Rishi, for you. A thank you. It's Annie Palin. I've lost nearly 5 stone. Mr. Singhal did my op in January 2021. Wow, that's a huge loss. Well done, Annie.
That's very good, Annie. Thank you for letting us be a part of your journey, and we are here if you need us. But
yeah, no, absolutely, right. Let me get some more of these questions. So Lavina has a question. She says, how long does the honeymoon period last, even just on average, please? That's a really difficult question to answer, Lavina, because everybody is different. You know, I've known patients where the honeymoon period has only lasted 6 weeks and then their hunger has come back ferociously. And then I've had patients that the hunger 2 years post-surgery and they still don't feel hungry. So Rishi, can you give a better answer than me? Because mine is very, very vague. It all depends on the patient and we can't predict when the honeymoon period is going to be over.
I had a very difficult question asked of me yesterday, actually. Same question. And the patient whom I did a sleeve on yesterday morning asked me yesterday evening that I'm feeling hungry. And I did not know what to say. I know the ghrelin levels go down, but I think it takes time for things to go down.
Just so ghrelin is the hunger hormone. That's
correct. Ghrelin is the hunger hormone. So even if I remove your stomach, within 6 hours, there's still hormone that is circulating in your body. Of course, we know that ghrelin has a short T half, which means it disappears very rapidly from the body. But I think that's possible to feel hungry immediately after surgery. How long does it last? Well, I think it's variable. Scientifically, you will say that 2 to 3 years after surgery, your body starts producing some ghrelin. So the other parts of the body take up the function of the stomach and they start producing some ghrelin. It will never be to the same level as it used to be before the operation. That won't happen. But 2 to 3 years, you will start seeing some reduction in effects. But how early can it happen? I don't know whether it's actually head hunger or actually real hunger. I don't even know that.
Yeah, so, and I would assume that immediately post-surgery, a lot of it possibly could have been head hunger because all of a sudden something's taken away from you, and your body is in that survival mechanism where, you know, 24 hours before you've not eaten, or well, you've not eaten very much, and then you might be, you know, in theaters, and then maybe for 12 hours you've not had anything. So the brain is automatically going to think, I need something, where's my nourishment, because it's not had its breakfast, lunch and dinner.
That's right. That's right. So I think we need to differentiate between those feelings. But I think for the first 2 to 3 years, we should just work hard with the operation, learn good habits, so that when the effects of the operation start reducing, you are ready with your tools to work.
Yeah, absolutely. No, I completely agree. And it's how long is a piece of string? It's a very difficult question to answer, Naveen. And I know you said, yeah, just what an average, but it's normal for your hunger to return, because you have to remember that your brain is wired for survival, right? So if it's noticed that you are not, you know, the brain is primitive. It's still living in the caveman era, you know, where you would go and hunt and gather food. So, you know, it's programmed that when you see food, you want to eat it. You know, the brain doesn't realize Tesco's, Sainsbury's, and whatever supermarket is just around the corner and you have access to food. It is still in that primitive mindset. So it is programmed that if you see food, you'll want to eat it. You know, if you haven't eaten for a long time, or you're in a huge calorie deficit, it's going to create hunger to remind you that you need to eat for survival. So it is normal for some hunger to come back. The rate or the strength of which it comes back, we don't know. Everybody is so different. But I always say the honeymoon period in the first six weeks, 3 months, 6 months is when you've got to work on your mindset to start create those new habits that you will take with you. And remember, look, we're human. We're all going to have setbacks. We're going to take 4 steps forward, but we might take 3 steps back, and then we'll take another 3 to 4 steps forward, and maybe another 2 steps back. It's normal. That's how you learn about life, and that's how you grow as a person. So don't worry about this honeymoon period. Just focus on the habits that you're creating, and that's why it's called a lifestyle change. Right, I hope that's, oh, who's this? Leanne has asked a question. I'm due to get sleeved in January. Is there a way to tell if it's brain hunger or actual hunger? I was going to test you then, Rishi, but it's all right. I'll take that question. So
don't do this.
Yeah. So usually the difference between head hunger and real hunger is that the brain hunger is the head hunger. So usually it comes on really quickly, and you have a specific craving for a certain food. So, you know, it might be that you start all of a sudden craving chocolate. Okay, so that's generally how you know it's head hunger. It's going to be really quick. With real hunger, it comes on slow. You don't have a craving for a specific food. You've got time to prepare a meal. It happens probably generally every 3 to 4 hours, and that's real hunger. So that's how you can distinguish. I mean, there's a lot more behind it than that. If you don't know the difference, I always say, have a drink. Just stop, pause, and have a drink of fluid, because sometimes we confuse thirst with hunger. So I always say start with that and then reflect and think, what am I actually feeling? If it's before that 3-hour period, it generally could possibly be head hunger, but it could also be the fact that you're not eating enough. So your brain's trying to remind you that it needs to eat something. So again, it's the survival part of the brain that's kicking in there. So that's how you would know. Right, Leanne's got another question, Rishi. I have PCOS, and does that make me randomly crave things already? So it just makes me worry. Oh, sorry. Do you want me to help with that question, or what your theory?
I will have a very strict answer to that. So no is the answer. That's my feeling. I think a lot of the times we ascribe symptoms to other diseases that, like PCOS. I don't think that is correct. PCOS has its own defined set of problems, which we know can range from infertility to acne to hirsutism to many other things. But I don't think these dietary changes are a part of part of PCOS or cravings. But that's my opinion. That's my view. Not talking to patients regularly about diets and things. It's a surgical view.
Yeah, right. Okay. I think there is something behind PCOS and cravings, because it's related to estrogen and the androgens, testosterone. And I think that can possibly make you want to crave sugar, but there's no real confirmed evidence of that. That's me answering with my female head on, Rishi.
Yes,
Right?
that's why I did not get too opinionated.
Yeah.
I knew it will become a female male thing, but
That's right. But
but
you've got to
that's
be
why
careful.
I left it vague. I wasn't very dogmatic about it.
But look, what we do know about PCOS is that those women that do have PCOS are at more risk of developing something called insulin resistance.
Yes.
So insulin resistance generally means that, let's say, Leanne, you've got the PCOS and I haven't. So let's say we have one square of chocolate. I have a square of chocolate and so do you. Now our bodies are going to metabolize it differently because I haven't got insulin resistance, but you have. And what that means is if I have a bar of one bar of chocolate, I'm going to need a teaspoon of insulin to help bring my blood sugar down, because that's what insulin does. It regulates your blood sugar levels. Now for you, Leanne, because you've got PCOS, you might need 10 teaspoons of insulin to bring that sugar level down. And what that means is insulin is actually not, it doesn't just control blood sugar levels, it also helps you store fat. So that's why when you have insulin resistance, you tend to put more weight on around the tummy region. So to regulate maybe your PCOS, if you are gaining weight around the tummy region, is watching the amount of not complete carbs, your starchy carbs, but being mindful about refined carbs. So that's things like biscuits, cakes, chocolate, sweets, those sorts of things. Because when you have those sorts of carbohydrates in your diet, and I'm not saying you mustn't have them, just be mindful that your blood sugar goes up very quickly, but it drops just as quick. So when the level drops just as quick, you crave sugar because your body wants to regulate that blood sugar back up. But then your body also has to produce a lot of insulin to get that sugar level back to normal. So, and again, insulin also makes you hungry. As women have a tough life, that's all I can say. So, so I hope that helps you. And yeah, Leanne says she has got insulin resistance. So by having, are you having a sleeve, Leanne? Yeah. So that will help with your weight loss.
I think one thing we should tell our patients is that if you have PCOS, then surgery such as either a Roux-en-Y gastric, a standard gastric bypass or a sleeve can actually reverse it. So I see a lot of patients who have difficulty conceiving due to PCOS, which is one of the biggest problems we see with PCOS, that can actually be reversed with bariatric surgery.
Yeah, so improves fertility.
But you need a powerful hormonal procedure for PCOS. I have looked at some data on bands, just purely bands. I think sleeves and bypasses, I recommend more in PCOS, and especially women who are trying to conceive, I recommend a sleeve because I think that's the best operation you do in this age group of patients.
Yeah, and just to be not caught out post-surgery, you might feel that your fertility is low pre-surgery, but don't be caught out post-surgery, because with that rapid weight loss, you know, your estrogen levels will start to regulate and your fertility will improve twofold post-surgery. So you need to make sure you have good contraception, and the fact that we ideally don't want you to get pregnant in the first 12 to 18 months, because that's when you have the rapid weight loss and your body cannot provide nutrition for both you and child if you've had weight loss surgery. So just to be careful about that. And I think, Rishi, I think that's pretty much it.
Yes, I think so.
It's
been an hour. I think otherwise they'll just hoot us out.
We could go on all evening, couldn't we, talking about weight loss surgery and so forth. But thank you very much for joining me. I know we've had the summer off. You've been doing your projects, I've been doing mine, but we'll get together hopefully in we say a month's time, and then sometimes it's a little bit longer. But I don't know if you know Poonam Pradhan, Obs and Gynae consultant. I'm going to have her on at some point about female hormones. I think we need a female.
Well, let me know and I'll make sure that I do not go near Facebook that day.
Well, I don't know. I might even invite you, but you know, let's see. We'll have you. Right, so we'll organize another date for everybody, but I hope you've all found this useful, and thank you, Rishi, for joining us. It's an absolute pleasure having you on, having the banter, and yeah, is there anything else that you'd like to add?
Thank you for inviting me, Van. I look forward to the next meeting.